the diagnosis rests on the clinical signs, and we all aware about this classical clinical signs like fever for at least 5 days and presence of 4 out of the following 5 conditions like conjunctival injections, polymorphous rash, cervical lymphadenopathy, mucosal changes and acral skin changes, and the illness not explained by other known diseases. But the important part is that this is a clinical epidemiological case definition. This is not a diagnostic criteria. So we have to know that we should not be behind the fitting the criteria for the diagnosis of this disease. And it has been highlighted, and it should be highlighted more and more. It is the most common childhood vasculitis, and it is the most common cause of acquired heart disease in children. And it's nowadays we call it's a worldwide most common cause of acquired heart disease in children. We don't see much of acute rheumatic fever. Whatever we are seeing is the ravages of acute rheumatic fever, that is rheumatic heart disease, which has been there previously. So as have been highlighted by Dr. Suda also, that the diagnosis of KD depends, it also depends that in which age you are seeing. And in infants, there is the diagnosis of KD is almost always difficult, and it's almost always incomplete. We don't see much of complete KD in this age group. Almost, I would say 80 to 90% of infants, specifically less than 6 months, would not fit the criteria. And at this age, it is important that almost 50% of children, like infants, would develop coronary artery abnormalities. So this is a significant component that we should know that when to suspect Kawasaki disease. And other extreme is that KD can sometimes present in older children and adults. Similarly, the delays in diagnosis would be there again, and because of delays in diagnosis, again the chances of development of coronary artery abnormalities would be significantly high. So the KD is not a one disease, and we have an expanded spectrum of disease. When like it present in a differently in infants, it can present differently in older children and adults, but sometimes it can have a atypical manifestations. Whenever there are any other manifestation which are not described in the principal clinical features, these features like neurological features, renal manifestations, or any other abdominal manifestations, like these manifestations are there, then these are atypical Kawasaki disease. And few children, so like 1 to 2% of children can have a very severe disease like development of macrophage activation syndrome. So we have to identify these patients in a spectrum of Kawasaki disease, because this is a precision medicine in a Kawasaki disease, that we have to identify the different group, subgroup, and we have to treat differently. We have to identify this patient differently. So the macrophage activation syndrome can be seen in around 1 to 2% of children with KD, and it's almost 50% of children who had macrophage activation syndrome can develop coronary artery abnormalities or cardiovascular complications. So such a need for identifications of macrophage activation syndrome. So whenever we are dealing with the severe or refractory diseases of in Kawasaki disease, we should suspect the macrophage activation syndrome, and we should work up these children for that. So this is a similar child which we managed this child in an ICU setting, and this child remained almost a month in ICU and required several of therapies, developing the significant myocardial collapse, and ejection fraction was less than 20% and required several of therapies, and finally and the pro-BNPs were more than 1 lakh. So this suggests that this disease can come to the emergency settings and ICU settings also. That is known as a KD shock syndrome. So whenever we are dealing with the children in emergency setup, children with acute cardiovascular collapse or shock, where we are thinking most of the time septic shock, but blood cultures are negative, think about the Kawasaki disease as a differential. So missing a diagnosis of KD can have serious consequences, and something like this was a 17-month-old girl who came with a fever for 3 weeks, and there was excessive irritability and some generalized erythematous rash was there. But what happened was that there was a urine examination and which showed pyuria. And in infant, whenever you are having a pyuria, you would think a urinary tract infections. But the sterile pyuria, the most common cause is Kawasaki disease. And what more thing happened is that this child went on to have several investigations related to the pyuria, multiple urine cultures, ultrasound KUB, CT head, CT chest and abdomen, because fever was persistent despite all the antimicrobial. But what we were missing was that this is a child with Kawasaki disease, and this baby had developed several giant aneurysms, and further CT also confirmed. So the incomplete nature of this disease highlights that we have to think a differential in any prolonged fever, more than 5 days of fever in a children. Think this differential. If you will think, then only you will work of these children. So the pathogenesis of KD is still an enigma, but it is evolving, and it's disease which has several risk factors which has been highlighted. But the most proposed theory is that this is a disease which happens in a genetically predisposed individual with some unidentified, probably some infectious agent which is causing the pathogenesis. So you will listen many talks on this next. So the evidence in favor of genetic basis is that it's a skewed epidemiology. We have seen that the incidence of Kawasaki disease in Japan is highest. The recent paper in 2025, the incidence of Kawasaki disease has reached to more than 400 per 100,000 children in Japan, which is a very high. So something like that, they report 15,000 children per year with the Kawasaki disease in Japan. So occurrence in sibling and children with younger children suggests that there is some infectious etiology which is causing the molecular mimicry and in a genetically predisposed individual. So the cardiovascular assessment in KD is an important component, and we need to learn about the coronary artery abnormalities, KD myocarditis, KD shock syndrome, and if you don't treat that, up to quarter of patients can develop cardiovascular complications, and in less than 5% of children still can develop who received the treatment on time. So Professor Nazib Dada has first time described this as that it's not just coronary arteritis, Kawasaki disease is a myocarditis too. And we ignore this entity, something like that, because the myocarditis is an integral component of Kawasaki disease. It's there in almost always in all patients, but the symptomatic myocarditis will seen in almost 5 to 10%, something they can present with a cardiovascular collapse or hemodynamic instability. So while the coronary artery abnormalities develop in 15 to 20%, myocarditis is almost universal, and sometimes they can present to the pediatric ICUs or emergencies presenting like a KD shock syndrome. And the cardiovascular involvement has been, as highlighted by Professor Suda also, that it's not just limited to the coronary artery abnormalities. We can have several other things like myocardial dysfunctions, valvular regurgitation, aortic root abnormalities, and pericardial abnormalities. So the coronary artery abnormalities in our cohort also, the prevalence of coronary artery abnormalities has significantly risen, possibly because of several reasons, because of using the G-score system and more frequent echocardiography, which we can do in-house echocardiography, and also we are nowadays we are doing CT coronary angiography in all patients who are having a very severe disease or wherever we are having any suspicion of coronary artery abnormalities. So CT coronary angiography is an imaging paradigm which Professor Manful Singhal will be talking in his talks, and the therapeutic regime of Kawasaki disease has evolved over the years. And what in 1967 was when we didn't had any treatment, something like that, it started with some erythromycin and aspirin. Now we are reaching with standard of care as IVIG with treatment intensification with several other things, and IVIG treatment of IVIG resistant KD. So by this time you know that why should KD be diagnosed and treated, because KD is not a benign disease of one childhood, and it can leave behind several sequelae, and if you don't treat, almost quarter of patients can develop coronary artery abnormalities, and these are the long-term effects of this disease. So patients with coronary artery abnormalities as a result of childhood KD remain at risk of several cardiac sequelae throughout their life. So just I will conclude that the KD is the commonest cause of acquired heart disease in children, and it's not a one-time disease of childhood, and it can leave behind several sequelae like coronary sequelae, myocardial sequelae, systemic sequelae, and adult coronary artery disease. So I will conclude by something which quoted by Professor Nazib Dada is that Kawasaki disease does in 5 days what atherosclerosis does over 5 decades. Thank you.
Thank you, Rakesh. This talk is now open for comments and questions.
I have a question about since the initial manifestation could mimic any of the viral examples, does the delay by the time the patient is referred and diagnosed, does the delay treatment impact the outcome of these patients? Does it may take a few days or a few months by the time patient comes to the or any
Thank you for the question. So basically, this is a most important component because the diagnosis is here is clinical, and in this age group we have several other differentials like viral exanthems and more so in a tropical country like us. So, but nowadays probably in last 1 decade there is an increased ascertainment of this disease, and the pediatricians are more tuned to the diagnosis of this disease. And yes, definitely we have to treat this disease within 10 days. If we have to diagnose and treat with this disease within 10 days, because the IVIG should be given as soon as possible. It will, if there is a delay after 10 days or within even after 10 days, the development of coronary arteriomyopathy, chances of development of CA is very significant. So this factor is a very important, but we have to take into the context because, and more important is that the symptoms appears in a temporal sequence also. Sometimes fever will be there, and after fever there will be development of rash. By the time the child will reaching you, something like conjunctival injection may or may not present. So we have to take all the clinical features and we have to ask in history. Mother is a very keen observer and they will tell that there was red eyes, or this is a very important component, that whenever a young child coming with fever, the differential of Kawasaki disease should be there with the clinician. If there is a differential, people like you have to ask or you have to see these clinical features.
I think in the hall we have experts from all over the country, and they're all very well versed with picking up TB, but I think I'll still emphasize the fact that when a child comes with fever and the fever crosses day 4, day 5, the thing you must never do is start antibiotics without a reasonable diagnosis. Antibiotics will really mess up that situation. So what happens usually is you are given a course of broad-spectrum antimicrobials, fever persists, the parents go to another pediatrician, they change the antimicrobial, fever persists, they go to yet another pediatrician, they go on to intravenous antimicrobial. A child who has had more than one course of antimicrobial and fever is persisting, I think our threshold for TB should be really low. Just this morning, we had a patient who Dr. Suda saw. This was a doctor's child. The baby developed fever, 7-month-old developed fever, given a series of antimicrobials. The treating unit thought of Kawasaki disease, but did not treat, saying that the echo is normal. Now, echo is not essential for diagnosing Kawasaki disease. In fact, quite often it leads you astray. So the question that you have asked, I think, is very, very important. We really have to have a very low threshold for Kawasaki disease. We have to remember that antimicrobials are not antibiotics. Children do not need antimicrobials for most fevers. And if there is reason to start an antimicrobial, we must have some diagnosis. So, Dr. Pratap?
How easy to or difficult to make diagnosis of ATP-HTD, and what percent of children present with atypical manifestations, and you have the cohort of only 18 to 20.
So question is that like now how difficult to make a diagnosis of KD in atypical manifestations. So it's almost always not easy. So because the atypical KD will not present to you basically as a rheumatologist or like something like, it will present to several specialties. Sometimes like we have seen, it will come to the neurologist with something like a seizure or something like a facial nerve palsy, which I can still remember an adult, 30-year-old adult who came with a facial nerve palsy, and she had all the features of Kawasaki disease, but what was odd was is, and then it was a facial palsy, and to convince that it's a Kawasaki disease, it take a very much time. But there are several other manifestations like renal manifestation like acute kidney injury. Sometimes it can be just a urinary abnormality like sterile pyorrhea, which we see, and something like other atypical manifestation which we see. So it's easy to make a diagnosis of atypical KD when you are having a features of all complete KD. But if there are only a fever and their atypical manifestation, is almost always a difficult thing, and diagnosis of KD will evolve sometimes, and we have to treat KD rather than waiting for the fulfilling the criteria at that time. We don't have a specific data for atypical Kawasaki disease, how many patients we have not looked into this, but possibly we can see that.
Okay. If there are no more questions, I thank Dr. Rakesh for this talk.
Good afternoon, everyone. The next session is the 15th, Professor Kumar, lecture in pediatric immunology. I request Professor Sujit Singh and Professor Amit Rawat to please chair the session.